Hey guys, welcome to one more episode of our AI podcast. So, today we're going to talk about chest pain. I'm your host and your guest, ChatGPT. ChatGPT, how are you? Are you ready to start our beautiful conversation?
Absolutely, I'm ready. Thanks for having me. Chest pain is a crucial topic, so let's dive right in.
Amazing. I want to start the episode with a nice acronym, Socrates. Could you explain us how Socrates is related to chest pain?
Absolutely. The Socrates acronym is a useful tool for assessing chest pain. It stands for site, onset, character, radiation, associations, time course, exacerbating or relieving factors, and severity. It helps guide a thorough and systematic evaluation.
Interesting. I want to get more into what Socrates means, but before we do that, let's talk generally about what chest pain indicates. And yeah,
Chest pain can indicate,
sorry for
including
interrupting you. Just give us general examples.
Sure. Chest pain can range from something as benign as indigestion to serious conditions like a heart attack. It's important to evaluate the characteristics to understand the cause.
Interesting. Okay, so let's see. Let's say I have a person coming into the doctor's office. Let's say I'm the physician, or let's say we're looking at it from the perspective of the patient. So, you know, um, what would the patient kind of expect? So let's use the acronym Socrates then. Let's start with S, sight. I assume. So can you explain us what kind of questions should the doctor be asking? What kind of questions should the patient be expecting?
Certainly, the doctor would ask the patient where exactly the pain is located. They might ask if it's on the center, left side, or if it spreads to other areas. This helps narrow down potential causes.
And why is it important to ask about the onset and the character of the pain?
Understanding the onset and character of chest pain is crucial because it helps narrow down potential causes. For instance, sudden, sharp pain might suggest a different issue than a gradual, dull ache. It guides the diagnostic process and ensures the right treatment approach.
Amazing. Okay, and what about radiation and associated symptoms? Why are those important?
Radiation and associated symptoms are key in diagnosing chest pain. Radiation describes where the pain spreads, which can indicate specific conditions. For example, pain that radiates to the arm or jaw could suggest a heart attack. Associated symptoms like shortness of breath or nausea provide additional clues that help pinpoint the exact issue.
That's very helpful. Thank you. Okay, and why is the timing important, or if we're exacerbating or not?
Sure, timing is crucial because it helps distinguish between different causes. If pain worsens over time, it might indicate a serious condition like a heart attack. Knowing when the pain started and if it's getting worse helps guide diagnosis and treatment.
Mm-hmm. Interesting. So, I got some constructive criticism about saying interesting too much, and they said I should replace it with thanks. That's very helpful, which is really sweet. Anyway, it just doesn't roll in my tongue at the moment. Okay, exacerbating and severity. Let's talk about ENS of the Socrates acronym.
Sure, exacerbating and severity in Socrates help pinpoint what makes the pain better or worse and how intense it is. This provides valuable clues for diagnosis, indicating whether the condition is serious or not. It's essential for understanding the full context of the chest pain.
Mm-hmm. Okay, so let's talk about some red flags. So let's say you're sitting in your couch and you're relaxing. What kind of things can happen that can, um, be considered as red flags in regard to having some chest problems.
Red flags for chest problems while you're relaxing could include sudden, severe chest pain, pain that radiates to your arm or jaw, shortness of breath, or feeling faint. These symptoms could indicate something serious like a heart attack and would need immediate medical attention.
Yeah, that makes a lot of sense. Interesting. So, if you're the doctor or if you're the patient, what do you expect from your doctor to ask about in terms of risk factors? What risk factors would a doctor want to ask about?
A doctor would likely ask about risk factors such as smoking, high blood pressure, diabetes, family history of heart disease, and cholesterol levels. These factors help assess the likelihood of heart-related issues.
Mhm. And yes, and I assume, okay, you need to know about drug history too, eventually, if they take any statins or any aspirin. Want to know about the social history too, to see if they smoke or they take alcohol. What's a good way to do this while remaining respectful and respecting the other person's boundaries, you think?
It's best to approach these questions with empathy and non-judgment. You can explain that understanding their medical and social history helps provide the best care. Being open and explaining why you're asking builds trust and helps the patient feel more comfortable sharing.
Interesting. And it's important, guys, to know like if they've got hypertension or diabetes or high cholesterol, you can see that, you know, well, roughly if they have more risk for certain diseases, maybe some CVDs, cardiovascular diseases, etc. And okay, now how can we differentiate between like common chest pain and maybe something that's more serious?
Common chest pain, like from muscle strain, tends to be more localized and linked to specific movements or breathing. Serious chest pain, especially if it's sudden, intense, or radiates to other areas like the arm or jaw, may indicate a heart issue. Other red flags include shortness of breath, dizziness, or nausea, which would need immediate medical attention.
Mm-hmm. Interesting. Okay, or as we said, thank you, that's very helpful. Okay, I want you to explain to us what ICE means. What's this acronym that's really popular in medicine?
Sure, ICE stands for Ideas, Concerns, and Expectations. It's a framework used by doctors to understand a patient's perspective, their thoughts on what's happening, their worries, and what they hope to achieve from the consultation. It helps tailor the care to the patient's needs and ensures they're fully heard.
Yeah, and that's really important. Okay, going back then, going back to common versus serious, how would the doctor treat these individuals differently if he notices that, oh God, this is serious? And again, the patient, what should the patient be expecting?
For serious chest pain, a doctor would quickly conduct tests like an ECG or blood tests to rule out heart issues and might administer medications or recommend hospitalization. For less serious pain, treatment might involve rest, pain relief, or lifestyle advice. Patients should expect thorough evaluation and clear instructions on next steps depending on the severity.
Mhm. And also, I wanted to ask, I assume that although we have people that have common and serious chest pain, some of them, most of them, because they're not physicians, and we're all scared when we feel some pain suddenly. They don't know if it's like serious or not, so they might go to A&E or secondary care or and I wanted to ask, I assume you have a mixed variety of cases in primary care, A&E, and secondary care, and they're all a mixture of common and serious cases.
Yes, absolutely. In primary care and emergency settings, you'll see a mix of both common and serious cases. Many people come in because they're unsure how serious their chest pain is, and it's always better to be cautious. It's the healthcare provider's role to differentiate and ensure appropriate care.
Interesting. Okay, let's go forward then. Okay, so let's think about some cardiac causes of chest pain now. Can you explain to us three? Let's talk about pericarditis, stable angina, and unstable angina, and explain to us where does the phrase and STEMI ACS slash STEMI. Can you explain how these are connected too?
Certainly. Pericarditis is inflammation of the pericardium, often causing sharp chest pain that worsens with breathing. Stable angina is chest pain triggered by exertion, relieved by rest. Unstable angina is more severe, occurring even at rest and can be a sign of an impending heart attack. Non-STEMI, non-ST elevation myocardial infarction, and STEMI, ST elevation myocardial infarction, are types of heart attacks, with ACS, acute coronary syndrome, being an umbrella term for conditions like these.
Okay, can we go a bit deeper into this?
Of course, non-STEMI is a heart attack without the classic ECG changes seen in STEMI. It usually indicates partial blockage of a coronary artery. STEMI, on the other hand, involves a complete blockage and shows distinct changes on an ECG. Both require urgent medical attention but have different treatments. ACS covers any condition brought on by sudden reduced blood flow to the heart.
Can we get into the etymology of these words too, please?
Certainly. Pericarditis comes from peri, meaning around, card referring to the heart, and itis indicating inflammation. Angina is derived from the Latin word angere, meaning to strangle or choke. Non-STEMI and STEMI stand for non-ST elevation myocardial infarction and ST elevation myocardial infarction, respectively, with infarction meaning tissue death due to lack of blood supply.
Hmm. Interesting.
Let
Okay.
me know if
So, sorry for interrupting you. I was going to ask the differences that we should expect in terms of pain. Why does pericarditis have a characteristic sharp pain, whereas stable and unstable angina have a dull ache?
the sharp pain in pericarditis is due to inflammation of the pericardium, which can irritate surrounding tissues and nerves. This creates a sharp, stabbing sensation, especially with breathing. Angina, on the other hand, is caused by reduced blood flow to the heart muscle, leading to a dull, pressure-like ache. This difference reflects the underlying causes and how they affect the body.
And why is unstable angina not relieved by GTN, whereas stable angina is relieved completely by rest or GTN?
Unstable angina is more severe because it indicates a higher level of obstruction or narrowing in the coronary arteries, so the pain persists even at rest or with medication like GTN. Stable angina, however, occurs predictably with exertion and is usually relieved by rest or GTN, reflecting a more stable plaque and less severe narrowing.
Can you explain to us what GTN is?
GTN stands for glyceryl trinitrate, commonly known as nitroglycerin. It's a medication that relaxes blood vessels, improving blood flow to the heart and relieving chest pain associated with angina.
Mm-hmm. Interesting. Okay, so what about unstable angina now? Can it be brought on by exertion or stress?
Yes, unstable angina can indeed be triggered by exertion or stress, but unlike stable angina, it can also occur unpredictably, even at rest. This unpredictability signals a more serious condition and requires urgent medical attention.
Mm-hmm. Interesting. And let me ask you one more question about that. So, unstable angina, um, uh, are older people more prone to this, or what other kind of characteristics? Are men or women more prone to this?
Older people are indeed more prone to unstable angina due to the cumulative effects of aging on the cardiovascular system. Men are generally at higher risk, but postmenopausal women also face increased risk. Other
Mhm.
factors include a hip.
Sorry,
Let me know if
continue.
there's anything.
No, no, please continue. Sorry for interrupting.
No worries. So, other factors include smoking, high blood pressure, diabetes, and high cholesterol, which all contribute to the development of unstable angina.
Mhm.
It's a complex.
Please
Anything
continue.
else you'd like?
I'm just saying just to show that I'm listening.
Got it. Feel free to jump in with any questions whenever you're ready.
Okay, so I wanted to ask a bit more about pericarditis. Is radiation present in pericarditis, and what about in unstable and stable angina, and why?
In pericarditis, pain can sometimes radiate to the shoulders or neck, but it's typically more localized. In unstable angina, pain often radiates to the arm, jaw, or back, similar to a heart attack, due to reduced blood flow. Stable angina also causes radiation, but usually with exertion and relief with rest. The pattern of radiation helps differentiate these conditions.
I see. Okay. And I'm still a bit unsure why we have this radiation.
Radiation occurs because the heart and certain other areas share nerve pathways. When the heart is in distress, the brain can interpret the pain as coming from other areas like the arm or jaw. This is called referred pain, and it's a common feature in cardiac conditions.
Okay, interesting. Okay, so let me ask you one more question now. What's how can we relieve some of the pain with pericarditis, and why? By sitting forward, perhaps? Is it worse if we're lying flat?
Yes, sitting forward can help relieve the pain in pericarditis because it reduces pressure on the inflamed pericardium. Lying flat can worsen the pain as it increases contact with the irritated pericardium, making it more uncomfortable.
Okay, so before we go forward, from what I understand, let me know if I'm right, pericarditis has to do with the inflammation of the pericardium, although I'm still not sure how it's caused and why. And then stable and unstable angina have to do with an ST segment elevation, this unstable one, right? Or no?
You're correct about pericarditis. It's inflammation of the pericardium and can be caused by infections, autoimmune conditions, or other factors. For unstable angina, it's not necessarily linked to ST segment elevation, chest pain, and doesn't cause the same ECG changes. It's more about the severity and unpredictability of the symptoms.
Let's talk a bit more about the angina, please, and the unstable angina, because I still haven't exactly, besides correlating them to chest pain, I don't understand their mechanism. And I know I've asked, but I kind of want to reinforce this.
Stable angina occurs when the heart muscle temporarily doesn't get enough blood flow, often during exertion, causing predictable chest pain. It's usually due to partial blockages in coronary arteries. Unstable angina, however, is more serious because it's caused by sudden reduced blood flow to the heart, often due to a ruptured plaque. This can happen even at rest and signals a higher risk of heart attack.
And why is this different from myocardial infarction or heart failure?
Unstable angina is a warning sign that a heart attack or myocardial infarction could happen soon,
Mm.
but there's still some blood flow. A myocardial infarction occurs when blood flow is completely blocked, causing damage to the heart muscle. Heart failure, on the other hand, is when the heart can't pump blood effectively, often due to damage from previous heart attacks or other conditions.
I see. Interesting. Okay, let's continue then. Let's talk slightly more about these so we understand them. So, if we want to do an investigation as a doctor, or if we're a really interested patient and we want to know that we've been taken care of, what should be expecting from the doctor to investigate from its multidisciplinary team for stable angina, pericarditis, and unstable angina.
For stable angina, you can expect tests like ECG, stress tests, and possibly coronary angiography. For pericarditis, the doctor might perform an ECG, echocardiogram, and blood tests to check for inflammation. With unstable angina, expect similar tests as for stable angina, but with more urgency, and possibly admission to monitor and manage the condition.
Interesting. Okay, so let's break this down a bit simpler. So, unstable angina, when it comes to investigations. So, what would a raised troponin level say mean?
Raised troponin levels typically indicate heart muscle damage, often seen in conditions like a myocardial infarction. In unstable angina, troponin levels are usually normal or only slightly elevated because there's no significant heart muscle damage.
Hmm. And then in unstable angina, we also have changes in the ST segment and in the T wave.
Yes, In unstable angina, you might see ST segment depression or T wave inversion on an ECG, but not the elevations seen in a full-blown heart attack. These changes suggest ischemia, but without complete blockage.
Hmm. What about T wave inversion? Would we see that by any chance? Or sinus tachycardia?
Yes, T wave inversion can be seen in unstable angina as a sign of ischemia. Sinus tachycardia, or an elevated heart rate, can also occur as the heart tries to compensate for reduced blood flow.
Why do we see these things in unstable angina?
These changes occur because the heart isn't getting enough oxygen, causing electrical changes in its normal rhythm. The ST segment depression and T wave inversion reflect this reduced blood supply. Sinus tachycardia happens as the heart works harder to pump blood through partially blocked arteries.
Um, I'm still a bit confused about why the ST segment has its change and why the T wave has a change and why sinus tachycardia is present. But also, if, besides explaining those, which I would love you to do, can we also talk a bit about chest X-rays? Do we need them when investigating unstable angina?
The ST segment changes and T wave inversions reflect changes in the heart's electrical activity due to ischemia or reduced oxygen supply. Sinus tachycardia happens as the body tries to increase blood flow. Regarding chest x rays, they are used to rule out other causes of chest pain, like lung conditions, but they don't diagnose unstable angina directly.
I see, I see. Can we do a bit of a more of a deep dive in the ECG of someone with unstable angina?
Sure. In unstable angina, the ECG might show ST segment depression or T wave inversions, indicating subendocardial ischemia. These changes are often transient and can normalize when the patient is not experiencing pain. It's a sign of temporary reduced blood flow without complete blockage, which differentiates it from a myocardial infarction.
Mm-hmm. I see, I see. Okay, let's talk about the investigations we need to do with stable angina. Obviously, we said we need to take clinical history. We want to take some bloods and see the level of troponin. Now, I understand that ECG might not be the easiest thing to do because uh, during episodes, it might resolve quickly and then we won't get a representative ECG. Am I wrong?
You're correct. ECG might not always capture changes, especially if the episode is brief or resolves quickly. In such cases, stress tests or ambulatory monitoring might help catch abnormalities. These methods can provide a clearer picture of heart function under stress or over time.
Amazing. Okay, and let's go back to pericarditis. I assume we'll take bloods in this case. What should we be expecting? Sorry, guys, from the troponin levels and why?
In pericarditis, troponin levels can be normal or slightly elevated if there's some involvement of the heart muscle, myocarditis. Typically, the elevation is less pronounced compared to a myocardial infarction. This helps differentiate between pericarditis and a heart attack.
I see. I see. Can we do a bit of a deep dive into this?
Certainly. In pericarditis, if troponin levels are elevated, it suggests that inflammation might be affecting the heart muscle, leading to myopericarditis. However, this elevation is usually not as high as in a myocardial infarction, where troponin levels rise significantly due to actual damage to heart muscle cells. This distinction is important for diagnosis and management.
So, what's the etymology of troponin and explain how it relates to its function?
The word troponin comes from the Greek tropos, meaning turn or change, reflecting its role in muscle contraction. Troponin is a protein that helps regulate the contraction of heart and skeletal muscles. Elevated troponin levels indicate damage to heart muscle cells, often seen in heart attacks or other heart conditions.
Mhm. Let's talk a bit about management now. So, how will we manage a patient with unstable angina? We, yeah, let's talk a bit about calculating risks, perhaps what medication we might give them, angiograms, stent insertion, CABGs.
Managing unstable angina involves quickly assessing and stabilizing the patient. Medications like nitrates, beta blockers, and antiplatelet agents are commonly used. Risk is often stratified using tools like the TIMI or GRACE scores. An angiogram may be performed to identify blockages, and depending on the severity, treatments like stent insertion or coronary artery bypass grafting, CABG, might be necessary.
Can you explain to us further what CABG and angiograms are and perhaps give us, the etymology as usual?
Certainly. An angiogram is a diagnostic procedure where dye is injected into the coronary arteries to visualize blockages. Angio refers to vessels, and gram means a record or image. CABG, or coronary artery bypass grafting, is a surgical procedure where a healthy artery or vein is grafted to bypass a blocked artery. Coronary relates to the heart's arteries. Bypass means creating a new pathway, and graft refers to the transplanted vessel.
One more time, please, sir.
Sure. An angiogram is a diagnostic test where dye is injected into the coronary arteries to see blockages.
Mhm.
Angio means vessel.
I see.
CA.
Wow. Continue. Sorry.
No problem. Let me know if you'd like to dive deeper into any part of that.
Yes, you said angio means vessel.
Yes, angio means vessel, and gram refers to a record or image. So an angiogram is an imaging technique for blood vessels.
Mm-hmm. Interesting. And so we stain the cells to see the blockages, assuming the stain makes it easier to see. Um, is that right?
Exactly. The dye or contrast agent highlights the blood vessels on imaging, making blockages or narrowing easier to see. This helps doctors identify problem areas in the coronary arteries.
Okay, let's talk about medication and GTN. Remind us what GTN is. What's GTN spray, beta blockers, and why are these things useful in stable angina?
GTN stands for glyceryl trinitrate, commonly known as nitroglycerin. GTN spray helps relax and widen blood vessels, improving blood flow to the heart and relieving chest pain. Beta blockers reduce the heart's workload and lower blood pressure, making them useful in stable angina by preventing chest pain during physical exertion.
And why does nitroglycerin have this effect on the blood vessels? Why don't we use? And I assume we don't. It's not as severe, so we start using CABG.
Nitroglycerin, GTN, works by releasing nitric oxide, which relaxes the smooth muscles and blood vessels, causing them to dilate and increasing blood flow to the heart. This reduces the heart's workload and alleviates chest pain. For stable angina, since the condition is less severe and doesn't involve complete blockages, treatments like medications are often sufficient. CABG is reserved for more severe cases with extensive blockages.
Mm-hmm. I see. And can you remind me one more time, because I'm a bit of a dummy, what CABG is?
Not at all. CABG stands for coronary artery bypass grafting. It's a surgical procedure where a healthy blood vessel is taken from another part of the body and used to bypass a blocked coronary artery,
Got it.
improving blood flow to the heart.
And is it usually the one on the leg that's used?
Yes, the saphenous vein from the leg is often used for CABG. Sometimes the internal mammary artery from the chest is also used because it has good long-term results.
Okay, and how about in pericarditis? What kind of management do we expect in pericarditis? Anti-inflammatory medication, perhaps, something like that?
Yes, management of pericarditis often includes anti-inflammatory medications like NSAIDs to reduce inflammation and pain. In some cases, colchicine is also used to prevent recurrence. Rest is important, and if the condition is due to an infection, treating the underlying cause is crucial.
Hmm. What's NSAID? And what about steroid therapy?
NSAID stands for non-steroidal anti-inflammatory drug, which helps reduce inflammation and pain, like ibuprofen. Steroid therapy might be used in more severe cases or when NSAIDs are ineffective. Steroids help reduce inflammation by suppressing the immune response.
Hmm. Could you elaborate on the effects of steroids?
Steroids, like prednisone, reduce inflammation by dampening the immune system's activity. They inhibit the production of inflammatory substances, providing relief from swelling and pain. However, they must be used cautiously due to potential side effects, especially with long-term use.
Okay. And I don't understand exactly the mechanism of action of them, though. Do we have different types of steroids? Are the things bodybuilders get what we're talking about?
Steroids used in medical treatment, like prednisone, are different from anabolic steroids used by bodybuilders. Medical steroids are anti-inflammatory, reducing immune system activity and inflammation. They work by mimicking cortisol, a natural hormone that helps control inflammation. Different types of steroids have varying strengths and durations of action.
And what's the difference between the ones bodybuilders get?
The steroids used by bodybuilders, called anabolic steroids, promote muscle growth and enhance physical performance. They mimic testosterone and have different effects compared to medical steroids, which primarily reduce inflammation and immune responses. Misuse of anabolic steroids can lead to serious health issues.
I don't understand the difference, though. I think you should go do a deep dive, please.
Sure, anabolic steroids are synthetic variations of testosterone aimed at building muscle mass and strength. They're used to enhance physical performance and appearance. Medical steroids, like corticosteroids, are used to reduce inflammation and treat conditions like asthma or arthritis. They have different mechanisms and uses, with anabolic steroids focusing on muscle growth and corticosteroids on reducing inflammation.
I see. Interesting. Okay, so let's talk about some other causes of cardiac chest pain. What about aortic dissection or cardiac tamponade?
Aortic dissection occurs when there's a tear in the aorta's inner layer, causing severe, sharp chest pain that can radiate to the back. It's a medical
Uh-huh.
emergency.
Wow. And
Around the heart,
oh, see, sorry to
and
interrupt you. Continue.
no problem. So, cardiac tamponade compresses the heart and leads to symptoms like chest pain, shortness of breath, and low blood pressure. Both conditions require urgent medical intervention.
What's the etymology of tamponade?
Tamponade comes from the French word tampon, meaning a plug or stopper. It refers to the compression of the heart caused by fluid buildup in the pericardial sac, which stops the heart from functioning properly.
Hmm. Can we elaborate a bit more on cardiac tamponade, please?
Certainly. Cardiac tamponade occurs when fluid accumulates in the pericardial sac, the lining around the heart. This buildup puts pressure on the heart, preventing it from filling properly, which can reduce cardiac output and lead to a drop in blood pressure. It's a medical emergency requiring prompt intervention, often involving pericardiocentesis to remove the fluid.
Mm-hmm. Interesting. Okay, and obviously arrhythmias, acute congestive cardiac failure, these things can also cause chest pain. Um, Interesting. Do you have anything to add in regard to other causes before we move on?
You've covered the main ones, but other causes can include conditions like myocarditis, pulmonary embolism, and even gastroesophageal reflux disease, GERD. Each of these can present with chest pain and needs careful evaluation to differentiate from cardiac causes.
Mm-hmm. And okay, if we had to, could you explain to us a hypothetical scenario now of someone that comes in to the doctor's office for and complaining for chest pain, and give us a scenario and don't let us know what the actual cause is, and we'll try to guess what the cause is based on the symptoms.
Sure, let's imagine a 55-year-old patient who comes to the doctor's office complaining of sudden, severe chest pain that started while he was at rest. He describes the pain as sharp and tearing, radiating to his back. He's also experiencing shortness of breath and feels lightheaded. What do you think could be the cause?
Hmm. Um, I'm thinking of an angina, but I assume I'm jumping into conclusions really fast here. Um, uh, Actually, you said sharp, and sharp isn't. We said that it's dull ache, which I still don't understand why it's dull ache for angina. Please remind us. Sharp was pericarditis. Um, uh, so Before you reveal the answer, let's try to think about what tests I should be doing. What tests should I be doing?
For this scenario, you'd start with an electrocardiogram, ECG, to check the heart's electrical activity. Blood tests, including troponin levels, would help assess for heart muscle damage. A chest x-ray could rule out other causes, and a CT angiography would be crucial to check for an aortic dissection. Does that make sense?
Kinda. So, can you remind me why checking troponin levels is very important? And also, can you remind us um, what other possible options we have besides angina and pericarditis?
Checking troponin levels is crucial because it helps detect heart muscle damage, often seen in heart attacks. Elevated troponin suggests a myocardial infarction or other serious cardiac issues. Besides angina and pericarditis, other possibilities include pulmonary embolism, aortic dissection, and gastrointestinal causes like acid reflux or esophageal spasms.
I see. Interesting. I'm not sure. So, what was the disease then?
The sharp, tearing chest pain radiating to the back, along with the sudden onset and lightheadedness, strongly suggests an aortic dissection. It's a medical emergency requiring immediate attention.
Why not pericarditis?
Pericarditis typically causes sharp chest pain that's often relieved by sitting up and leaning forward. The pain in pericarditis doesn't usually radiate to the back in the same tearing manner as seen in aortic dissection. Additionally, the described symptoms match the classic presentation of an aortic dissection more closely.
You're so clever. Wow. Okay. Let's do another one. Let's do another one, and let's also. Okay, I'm gonna start with the guessing which tests we should do.
Let's do it. Here's another scenario. A 70-year-old woman comes in with chest pain that started suddenly and is accompanied by shortness of breath and rapid heart rate. The pain is severe and radiates to her left shoulder. What test would you consider?
Left shoulder. Well, surely we have to do an ECG. If it's some kind of angina, we should see if there's ST elevation or something like that, or inversion of the T wave. Um, what else? Um, I don't know if it's pericarditis. What type of pain did you say it is?
The pain described was sharp and tearing, radiating to the back, which is characteristic of an aortic dissection. For angina, the pain is usually described as a dull, pressure-like sensation. You're right that an ECG would help identify changes like ST elevation or T-wave inversion, which are common in myocardial infarctions and some cases of unstable angina.
Okay, so question. Why is it a dull ache in angina?
The dull ache in angina is due to reduced blood flow to the heart muscle, causing ischemia. This type of pain is typically described as a pressure, heaviness, or tightness rather than sharp or stabbing. It's a result of the heart muscle not getting enough oxygen-rich blood, typically during exertion or stress.
Okay, and how come this results in a dull ache and not a sharp one?
The dull, achy pain in angina occurs because it's usually due to reduced blood flow to the heart muscle,
Yeah, yeah,
causing
yeah.
ischemia.
But why does ischemia feel like a dull ache instead of a sharp?
Ischemia causes a dull ache because it's a gradual process where the heart muscle is starved of oxygen,
Uh-huh.
leading to a
Sorry, continue. Sir.
This type of pain doesn't have the sharp, tearing quality of something like an aortic dissection, which involves a sudden physical tear in the vessel. Instead, the heart muscle's gradual oxygen deprivation creates a more constant, pressure-like discomfort.
Mm-hmm. Interesting. Okay, so let's continue this one. So you said it was sharp pain, radiates the left shoulder. Um, might it be pericarditis? Might it be some kind of heart failure? Might it be myocardial infarction?
Sharp, tearing pain radiating to the back is more characteristic of an aortic dissection,
Sir,
rather.
you forgetful. You gave me a second example.
You're right. If the pain is sharp and radiates to the left shoulder, it could point to pericarditis, especially if it worsens when lying down. Myocardial infarction usually presents with a dull, pressure-like pain rather than sharp. It seems more likely to be pericarditis or another cause of pleuritic chest pain.
Okay, nice. Let's go to pulmonary causes now. Pulmonary embolism, perhaps, pneumonia, pleural effusion, and let's talk about these things. We've talked about them in other podcasts, but it's good to repeat this knowledge. So, how would we describe pulmonary embolism pain?
Sure, let me know when you're ready.
Go for it.
Pulmonary embolism typically causes sudden, sharp chest pain that worsens with breathing. It's often accompanied by shortness of breath, rapid heart rate, and sometimes coughing up blood. It's a medical emergency that requires immediate attention.
Interesting. So, when it comes to pneumonia and pleural effusion, what kind of pain do we have?
Pneumonia often causes a dull, aching chest pain that can worsen with deep breathing or coughing. Pleural effusion, which is fluid buildup between the layers of the pleura around the lungs, can cause sharp, stabbing pain that also worsens with breathing. This pain can feel like it's coming from the affected side of the chest.
Interesting. So, could we also experience dull pain in the cases of pleural effusion? Could we experience sharp or dull pain in pneumonia?
Yes, pleural effusion can sometimes cause a dull, aching discomfort, especially if the fluid buildup is gradual. In pneumonia, the pain can also vary. It might be sharp if the pleura is involved, or more of a dull ache if it's deeper in the lung tissue.
So,
It often depends.
so I'm confused. When is it? So, what is the factor that will make it dull or sharp?
The location and extent of the inflammation determine whether the pain feels dull or sharp. If the pleura, the lining around the lungs, is inflamed or irritated, the pain is usually sharp and worsens with breathing. If the inflammation is deeper within the lung tissue, as in pneumonia, it can present as a dull, aching sensation. The type of pain can also depend on the severity and progression of the condition.
Hmm. I see. I see. So, with pneumonia and pleural effusion, is the onset gradual or sudden?
The onset of pneumonia is usually gradual, starting with symptoms like fever, cough, and malaise before chest pain develops. Pleural effusion can also have a gradual onset, often secondary to another condition like pneumonia or heart failure. However, the timeline can vary depending on the underlying cause.
How come they're gradual? And what about pulmonary embolism's onset?
Pneumonia and pleural effusion typically develop gradually because they often start with an infection or inflammation that worsens over time. Pulmonary embolism, on the other hand, usually has a sudden onset because it's caused by a blood clot blocking blood flow in the lungs, leading to immediate symptoms like chest pain and shortness of breath.
I see. Could you repeat this one more time?
Sure, pneumonia and pleural effusion usually develop gradually due to infections or inflammation worsening over time. Pulmonary embolism, however, typically has a sudden onset because it's caused by a blood clot blocking blood flow in the lungs, leading to immediate symptoms like chest pain and shortness of breath.
That makes sense. That makes sense. Okay, so but okay, I get why pneumonia and pleural effusion are what you said, but what about, and pleural effusion is basically the accumulation of fluid between the pleura, but or air.
Pleural effusion specifically refers to the accumulation of fluid between the layers of the pleura. When air accumulates in that space, it's called a pneumothorax. Both conditions can cause chest pain, but the underlying causes and treatments differ.
Got it. Okay, so I don't understand though. In the case of pulmonary embolism, isn't the process of the pulmonary embolism basically gradual?
The formation of a blood clot that leads to a pulmonary embolism can be gradual, but the onset of symptoms is usually sudden. When the clot travels to the lungs and blocks blood flow, it causes an abrupt onset of chest pain, shortness of breath, and other symptoms.
And can the people feel it? Can they feel it go like in their body traveling or no?
People usually don't feel the clot traveling. The first sensation they often experience is the sudden chest pain and shortness of breath once the clot lodges in the lungs and obstructs blood flow. The process is usually imperceptible until symptoms appear.
Hmm. Interesting. Okay, so let's continue then. What about breathing and coughing? Does it get worse when we have these diseases? What's the difference between illness and disease?
Breathing and coughing can indeed worsen the pain in conditions like pneumonia, pleural effusion, and pulmonary embolism, especially if the pleura is involved. Illnesses is a more general term for any condition affecting health, while disease usually refers to a specific medical condition with defined symptoms and causes.
One more time.
Sure, breathing and coughing can make pain worse in conditions like pneumonia, pleural effusion, and pulmonary embolism, especially if the pleura is involved. Illnesses is a general term for any health condition, while disease refers to a specific condition with defined symptoms and causes.
Got it. Okay, now let's talk a bit more about these three. I assume pulmonary embolism will make us feel breathless, but I also know that it causes swelling, like lightheadedness, dizziness, hemoptysis, calf pain. Could you explain all these on all these effects?
Certainly, pulmonary embolism can cause breathlessness because the clot obstructs blood flow in the lungs, reducing oxygenation. The swelling or edema often occurs in the legs due to poor circulation. Lightheadedness and dizziness are due to decreased oxygen and blood flow. Hemoptysis, or coughing up blood, can happen if the clot causes lung tissue damage. Calf pain is related to deep vein thrombosis, which can lead to a pulmonary embolism.
Hmm. Um, Interesting. Okay, I'm not sure about hemoptysis and calf pain. If you could kind of explain it a bit more.
Hemoptysis, coughing up blood, can occur when a clot causes damage to the lung tissue or blood vessels, leading to bleeding. Calf pain often indicates deep vein thrombosis or DVT, which is a common source of pulmonary embolism. The clot can travel from the leg to the lungs, causing the embolism.
And what about pneumonia? Do you experience sputum or hemoptysis or fever?
Yes, pneumonia can cause sputum production and sometimes hemoptysis, especially if there's significant lung inflammation. Fever is also a common symptom due to the body's response to infection.
I see. So they all kind of have similar symptoms. I wonder how we can tell apart without doing any extra X-rays or medical imaging and blood tests.
It can be challenging to differentiate them based on symptoms alone, as they can overlap. Detailed patient history and physical examination are crucial. For example, the presence of leg swelling or calf pain might suggest a clot, while cough and sputum are more indicative of pneumonia. But confirmation often requires imaging and tests.
Yeah, that's true. Okay, let's talk a bit about, like we did before, investigations and management. Can we start with pulmonary embolism? So, do we need to take ABGs or bloods, X-rays? What shall we do?
For a suspected pulmonary embolism, initial tests include an arterial blood gas ABG analysis, blood tests like D-dimer, and a chest X-ray. If these suggest a pulmonary embolism, a CT pulmonary angiogram is often performed for confirmation. Management typically involves anticoagulant therapy to prevent further clots.
Hmm. Interesting. Okay, and why do we choose these specific things?
We choose these specific tests because they help identify and confirm the presence of a pulmonary embolism. ABGs assess oxygen levels and gas exchange. D-dimer tests for clot presence, and chest X-rays rule out other causes. A CT pulmonary angiogram provides a definitive diagnosis. These tests are efficient and reliable in detecting clots.
And an angiogram is basically we have a record of the vessel.
Yes, exactly. An angiogram is an imaging technique that visualizes blood vessels to identify blockages or clots. In the case of a CT pulmonary angiogram, it specifically looks at the pulmonary arteries to detect any clots causing a pulmonary embolism.
I see. That makes a lot of sense. And okay, can we talk a bit about management now of pulmonary embolism? So, I assume we want to give some oxygen or maybe some kind of pain relief medication. How about anticoagulants? Would that be a good idea?
Yes, oxygen is often given to ensure adequate oxygenation, especially if the patient is experiencing shortness of breath. Pain relief can help manage symptoms. Anticoagulants like heparin or warfarin are crucial as they prevent the clot from growing and reduce the risk of new clots forming. This helps stabilize the patient and prevent complications.
I see, I see. And okay, in pneumonia now. What do we do? I assume we want to get some bloods. We want to see if there's any inflammation. Maybe a chest X-ray. And I assume we want to give some antibiotics. Six.
Exactly. For pneumonia, blood tests like a complete blood count can show signs of infection or inflammation. A chest x ray helps confirm the diagnosis by showing lung involvement. Antibiotics are the main treatment for bacterial pneumonia. Additionally, supportive care like fluids and rest is important.
And what about pleural effusion?
For pleural effusion, the key diagnostic tool is a chest x ray or ultrasound to visualize fluid buildup. If confirmed, thoracentesis, draining the fluid with a needle, can be both diagnostic and therapeutic. The underlying cause, like infection or heart failure, is treated accordingly.
Hmm. I see. Okay. Can you give us a scenario like before, but this time we have a pulmonary cause of chest pain?
Sure, imagine a 60-year-old patient presenting with sudden onset sharp chest pain that worsens with deep breaths. They also report shortness of breath and have a history of recent long haul flights. There's no cough or fever, but they mention calf pain. What do you think could be the cause?
Calf pain suggests deep vein thrombosis.
Exactly. The combination of sharp chest pain, shortness of breath, and recent long haul flights, along with calf pain, strongly suggests a pulmonary embolism. This is a medical emergency requiring immediate attention.
Let's do one more.
Sure. A 45-year-old patient comes in with a productive cough, fever, and dull chest pain that worsens with deep breaths. They also mention fatigue and recent flu like symptoms. What might be the cause?
Hmm. Um, can you repeat them, please?
Of course, the patient has a productive cough, fever, dull chest pain worsening with deep breaths, and mentions fatigue with recent flu like symptoms. What could be the cause?
Fatigue, flu-like symptoms, pneumonia?
Yes, exactly. The combination of a productive cough, fever, and chest pain, along with flu like symptoms, strongly suggests pneumonia.
Interesting. Perfect. Okay, can we talk about the
I'm sorry,
GORD?
but you've hit.
So let's talk about the GORD and the reflux then.
Absolutely. GERD, or gastroesophageal reflux disease, happens when stomach acid flows back into the esophagus, causing irritation. This can lead to burning chest pain, often called heartburn, which can sometimes mimic cardiac pain.
Hmm. Can you talk a bit more about the GORD?
Of course, GORD, or gastroesophageal reflux disease, is a chronic condition where stomach acid frequently flows back into the esophagus. This happens due to a weakened lower esophageal sphincter, leading to symptoms like heartburn, regurgitation, and sometimes even chronic cough or hoarseness.
And this might be confused for cardiac pain.
Exactly. The burning chest pain from GORD can feel similar to angina or even a heart attack. However, GORD pain is often triggered by eating, lying down, or bending over, and it improves with antacids, unlike cardiac pain.
Hmm. Yeah, that makes sense. And what are some red flags we should be looking out for GORD or reflux? Could you remind me the GORD, what it means in full?
Sure. GORD stands for gastroesophageal reflux disease. Red flags include difficulty swallowing, unintentional weight loss, persistent vomiting, or blood in vomit or stool.
Hmm. So, what about dysphagia?
Are you referring to foggy, as in brain fog?
No, no, no. I said dysphagia and perhaps melena and epigastric mass. Because I hear this, I don't know what it is.
Got it. Dysphagia means difficulty swallowing and can be a sign of severe GORD, strictures, or even esophageal cancer. Melena is black, tarry stools, which suggest upper gastrointestinal bleeding, possibly from ulcers or severe esophagitis. An epigastric mass could indicate a tumor or another serious condition affecting the stomach or upper abdomen.
Hmm. I see. Okay, that makes sense. Let's move on then. What are shingles? I know, guys, this is out of the blue.
Audio transcription shingles or herpes zoster is a viral infection caused by the reactivation of the varicella zoster virus, the same virus that causes chickenpox. It leads to a painful rash, usually on one side of the body, often with burning or tingling pain before the rash appears. It can sometimes mimic chest pain if it affects the chest area.
Interesting. Okay, so we've learned some things about chest pain. We'll keep this podcast short for today. And yeah, if we had to remember in a few sentences some things about what to do if we have chest pain or what our doctor should be doing, could you summarize those things for us?
Absolutely. If you have chest pain, take it seriously, especially if it's sudden, severe, or radiates to the arm or jaw. Seek medical help immediately if it's accompanied by shortness of breath, dizziness, or sweating. Your doctor should assess your history, do an ECG, check blood tests like troponin, and consider imaging to rule out serious causes.
Okay. Well, thank you for being a wonderful guest. And when I say you, I mean us, because I think ChatGPT is the knowledge of the crowd, the wisdom of the crowd. It's an unconscious being. It's a tool that we use to help each other out. And up until the next one, love you guys.